So, and Maggie is out of the office as well. So it isn't their fault. I told them it was fine. They have great people in their departments. They'll be here listening. They'll bring the information back to us for our September meeting because it wasn't going to be a decision made about anything super important in those areas. But the leadership from Ms. Agnes in the behavioral health area, as well as comments from the department, of course. I think what we have to recognize, because of the firm belief I have in creating the general practice of government, is that the executive department, the governor has asked for a 10% reduction in budget, which I'm sorry, I just can't go there with this budget. But whatever is brought in has to conform in some way to what the governor is requesting. We see whatever the consensus about the budget is. But I think it's important for all of us to keep in mind that the legislature passes laws and the legislature appropriates money. And so what we see today, what we see in December, will be very different from what we decide we're going to do in April. Not suggested that we're going to just spend every dollar that we have on the subjects that we think are most important. There are many state priorities, but there are going to be challenges involving what we see compared to what we have to do. And I am not going to be bashful. The session starts as soon as I get reelected. Now I'll be in Florida and I might be covered. Either way I win, right? It's okay. Anything. Representative Anderson.
Thank you, Chairman Lee. Can this committee direct the Human Services Department to establish a 1950 I State Plan Amendment?
That is all being worked on right
It
now,
is.
and that's part of what CMS has not yet responded on.
Okay.
So all of that, whatever our department puts together, they have been working on this.
So they are gonna apply for the
They were
amendment.
hoping that it would come back, but we stand clearly in our thumbs until the feds get back to us. So I would expect that we would have something on it.
So we have a plan.
I believe that's true. Mr. Solberg, is that correct?
Wait, I was looking for you. Here you are.
Oh, you're here, she's better. Okay, or you're here anyway.
Yeah, no.
Okay. I'm sorry, I didn't mean to call you absent. I didn't see you were sitting right there.
That's all right. Pam Sagnis, Department of Human Services, Chairman Lee, members of the committee. We are as a department working on the 1959, so a lot of the recommendations that were just noted by both Carlotta and also Carl are things that are either currently being implemented or are in the plans. And so the 1959, and also with peer support, just specifically, we've offered 3 of 4 scheduled trainings already for peer support specialists. We've trained just under 100 peer support specialists in the state. We've also completed a train the trainer. So we had 8 individuals that completed the train the trainer so that they'll be able to provide future trainings. As Carl mentioned, we just completed one of those trainings in Grand Forks. We have another one in Minot, and we will be looking to schedule more. We have 150 individuals who have signed up to become peer support specialists just following Recovery Reinvented, and that is peer support both in mental health and substance abuse, so it's not specific to one. I also wanted to note that we do have opportunities for peer support specialists to work through part of the Free Through Recovery program. So there are paid positions through those private providers. We don't mandate or set the salary for that pay, but we know peers that are being reimbursed at $40 an hour through some of those programs. The limitation with that right now is that's still a criminal justice program with funding that goes specifically to individuals through the DOCR. And so there certainly is opportunity for us to continue to advance that and look to broaden and enhance those services beyond the criminal justice population.
Wonderful. Okay, so we have applied now, or is going to apply?
Chairman Lee, Representative Anderson, members of the committee, we have not applied. The study gave us the numbers we needed in order to complete the fiscal and what's required. There will be cost, and so it certainly will be something that will be discussed as we head into this next couple of hearings.
I'm glad you're here to clarify that, because I knew we were working on that. So I didn't need to speak up. Other questions from Ms. Agnes? Anything else you would like to tell us about what we haven't already heard?
Madam Chair, members of the committee, I think I'll be providing the updates on the Children's Behavioral Health Task Force and also the school pilot. I don't know if we're doing that now or if we'll be doing that after lunch.
I think we're after lunch on that. Okay. All right, thank you very much. Anybody else under this particular category of adult and disabilities and legal updates? Then let us get started at this a bit. We're going to just give the beginning here to the other committee responsibilities, and Joelle Meyer is going to tell us about what's going on. So actually, this is just an FYI for us about some things that are happening in the health department.
Madam Chair, I just have a quick question. On the 1015, it mentioned that we were going to update on the implementation of the payment system. Did I miss that? Did we move it?
Did I miss it?
Yes.
Yes, I did. And that's what I've been sitting down there waiting for. Can you after that, and we'll let Joelle do this?
I'm sorry, what was
Are
that?
you able to come after lunch?
Yes, I am.
Okay, let's let Joelle. Sorry that I missed that phone. I'm blaming it on my busy things research. The blue light should be on, there you go.
Good afternoon, Chairman Lee and members of the Health Services Committee. My name is Joelle Meyer, and I am the Director for the Newborn Screening Program for the North Dakota Department of Health. My colleague Tammy Johnson, a Program Administrator within the Division of Special Health Services, and I will be providing information on the Newborn Screening Program and the Metabolic Food Program for individuals with phenylketonuria, or PKU, and maple syrup urine disease, or MSUD. Newborn blood spot screening is considered one of the greatest public health achievements of the 21st century. Newborn blood spot screening is a heel prick that is done on a baby shortly after birth that tests for certain rare and metabolic genetic disorders. North Dakota began screening in 1964 with one disorder called PKU. This has expanded to 49 disorders, some of which are now considered time-critical. Babies can appear healthy initially, but can become sick within hours after being born. Early identification and treatment is vital to the health outcomes of babies. Newborn blood spot screening is mandated by law in every state. However, parents may refuse the test in North Dakota. I have included the North Dakota Century Code administrative rules that relates to the newborn blood spot screening for your references. The Iowa State Hygienic Laboratory has processed North Dakota newborn blood spot specimens since 1992. Because of increased complexity, sensitivity, and cost of the testing, it is more efficient to outsource the specimens to another state rather than process them in North Dakota. A regional approach to process laboratory specimens in newborn screening programs is being used across the nation. In addition to North Dakota, Iowa currently processes their own specimens and provides services for South Dakota, and effective July 1st of 2018 for Alaska. Currently, specimens in North Dakota are transported via courier from all 12 birthing facilities to Iowa 5 days per week. The Iowa State Hygienic Lab processes specimens on a daily basis, 365 days per year. After the Milwaukee Sentinel Journal released an article in 2013 titled "Deadly Delays at Hospitals Across the Country Undermine Newborn Screening Programs, Putting Babies at Risk of Disability and Death," the Health Resources and Services Administration, HRSA, identified newborn screening timeliness as a priority and assigned a national committee to develop specific timeliness goals for states to effectively reduce disability, morbidity, or mortality. The committee recommended that all newborn screening results be reported to a healthcare provider within 7 days of life and no later than 5 days of life for time-critical disorders. To achieve the recommendations, newborn screening specimens shall be collected by 48 hours after birth and received at the laboratory, ideally within 24 hours of collection. The North Dakota Newborn Screening Program utilizes an advisory committee to guide the program. This committee has statewide representation and members with needed content expertise. The North Dakota Newborn Screening Program is currently meeting the timeliness goals statewide. However, disparities exist based on the day of the week and the location where a baby is born. For example, a baby that is born on a Thursday would have their specimen collected on Friday. The facility may have a courier service to transport the specimen. The facility may not have a courier service to transport the specimen to Iowa until Monday night, so the results would not be available until Tuesday. In this case, the baby born on Thursday would already be 5 days old when the results would be called to the healthcare provider. The healthcare provider then needs to notify the family and have them come to the office to assess the overall health of the baby and have confirmatory testing done. To consistently meet timeliness goals for all babies born in the state, the North Dakota Newborn Screening Program is planning to enhance the current courier service to transport specimen to Iowa 7 days per week, beginning July 1st of 2019. This concludes my portion of the testimony, and I'm happy to answer any questions you have before Tammy Johnson comes to the podium.
Any questions? Yes, Representative Rich.
Madam Chair, Ms. Meyer, two really quick questions. My first one is there a lab in North Dakota that has the capability and capacity to do these lab tests? And then my second follow-up question to that is, what is the actual cost savings of the state utilizing an out-of-state lab to provide this testing service?
Madam Chair and members of the committee and Representative Rich, the Iowa State Hygienic Lab has our costs really low because of that regional approach. The state laboratory here in Bismarck would not be able to process the specimens because of the amount of the equipment, and we had actually reached out to them when our state health officer, Mylin Tufte, had taken leadership role at our Department of Health, and we had asked for a number, and they were not able to process specimens, and they could not guarantee that they could be open 7 days per week, which would cause further damage to babies in the state. And the next question was the cost savings. They're able to keep, the Iowa State Hygienic Lab is able to keep our costs low because of that regional approach, and it's very common throughout the states. Our current fee is $75 per baby, and there's no cost for repeat testing at this time. And we're right in the middle as far as ranging from $0 to $162 for a specimen collection. $150 is what Minnesota, the neighbors across to the east, charge for a baby specimen. So we're kind of right in that middle. Does that answer your question?
It does, thank you.
Anything further? If not, thank you very much. Oh, okay, quickly, Representative.
Thank you, Madam Chair. Does that $75 include the courier fees?
Madam Chair and Representative McWilliams and members of the committee, yes, it does. The $75 includes the follow-up that is needed, the courier service, and administration for that.
Anything else? Thank you very much.
Thank you.
And stepping up, I'll tell you, my previous life, I stuck a lot of babies' heels.
Good afternoon. My name is Tammy Johnson, and I'm a program administrator with the Division of Special Health Services, and I'll be providing information on medical food for individuals with PKU and MSUD. PKU and MSUD are two disorders that do not allow the body to break down certain proteins. If these disorders are left untreated, brain damage or even death can result. Optimal management for PKU and MSUD includes a lifelong diet of medical food or formula and low-protein modified food products. Currently, North Dakota Century Code, Chapter 2517-03 requires the North Dakota Department of Health to provide medical food at no cost to males under the age of 26 and females under the age of 45 whom are diagnosed with PKU and MSUD, regardless of income. Offer for sale at cost medical food to females age 45 and over and males age 26 and over who are diagnosed with PKU and MSUD, regardless of income. Provide low-protein modified food products if medically necessary as determined by a qualified healthcare provider to females under age 45 and males under age 26 who are receiving medical assistance and are diagnosed with PKU and MSUD. Prior to the 2017 legislative session, medical food was provided to males up to age 22. During the session, legislation was passed which extended the age of males to under age 26 and to offer for sale at cost medical food to males 26 and over. Expansion of the metabolic food program could impact the department's budget as additional individuals order formula. Special Health Services has managed the metabolic food program since 2001. The formula provided is purchased from a small number of medical food companies. The division maintains an inventory of frequently ordered formulas, which assures timely access for individuals served through the program. As of June 2018, 26 individuals are ordering medical food, 25 of which have PKU and 1 with MSUD. In addition to providing medical food, Special Health Services administers multidisciplinary metabolic disorders clinics to help coordinate management for these rare conditions for children birth to 21 years of age. Additional references in the North Dakota Century Code 26.1-36-09.7 address applicable health insurance requirements. Although coverage for medical foods and low-protein modified food products is required in health insurance policies, the following caveats apply. Coverage is not required to the extent those benefits are available under a State Department of Health or Department of Human Services program. Coverage in excess of $3,000 per year is not required. Rather than gap filling after insurance is billed, Special Health Services is the primary payer of medical food formula and low-protein modified food products for females under the age of 45 and males under the age of 26. A policy change could be considered to address this issue. Currently, North Dakota Medicaid does not cover formula for inherited diseases of metabolism, which includes medical formula for PKU and MSUD. Women, Infants, and Children, or the WIC program, provides metabolic formula for eligible individuals, which would include pregnant women, breastfeeding women, new mothers, and children under age 5 with nutritional health risks who meet WIC guidelines. Depending on the individual's dietary needs, Special Health Services occasionally provides supplemental formula for WIC eligible individuals if WIC cannot provide needed amounts through the prescribed food package. 9 states that participate in the Newborn Screening, Technical Assistance, and Evaluation Program, or new STEPS, including North Dakota, responded to an informal survey regarding state-specific approaches to the provision of medical food. Their responses are included in Attachment A. There is a lot of variation between states. However, 6 of the states surveyed indicated that their medical assistance or Medicaid program covers the costs of medical food, and 5 states have a medical food program. This concludes my portion of the testimony. I'm happy to answer any questions you may have.
Thank you, Madam Chairman. Has there been a decision made not to have Medicaid cover these services, and if so, why? And if it hasn't been made, do you see value in having Medicaid coverage?
Madam Chair, Representative Shader, at this point in time, Medicaid does not cover these disorders. There hasn't been discussion indicating that they would include that metabolic food as part of a Medicaid provision. So I'm not sure how we can go forward with that at this time. Other states do, their Medicaid program does cover it, but ours does not.
Do you have an opinion on whether we should be covering it or not?
Madam Chair and Representative Schrader, I would probably have to decline giving you an opinion on that. I would think it would be beneficial for them to consider looking at that, but I don't have an opinion to give you based upon that. It would share the load and the costs for these individuals. Other states cover other conditions as well.